This week for EM5, we're going to talk about pregnant vaginal bleeding, specifically in the first trimester. And this is a really common complaint that we get in the ER. But I think that the algorithm and the workup can be a little confusing sometimes, whether these patients can be sent home or need an OB consult. But lucky for us, there's a pretty good algorithm that we can go through, and usually it involves parts of the history and using a pelvic ultrasound along with the beta-hcg. And a couple other labs to think about ordering for these patients are you probably need to get a hemoglobin, especially if they've been bleeding significantly. Make sure you get a type-in screen if they don't know their RH, because they might need RhoGAM if they're O-negative blood type. And I usually get a UA on pregnant patients just to make sure they don't have a UTI. So to start off, you're going to get a little bit of history from the patient. And at this point, you really need to assess, is the patient hemodynamically stable or not? That's the big first split in our algorithm. Because if they're not, then what's on your differential here? It's going to be ectopic, maybe a ruptured or hemorrhagic cyst. And either way, you need to start resuscitation and call OB because these patients might need to go to the OR. But if the patient is stable and they appear well, the next step is going to be to get a pelvic ultrasound. And the main question you're answering with the pelvic ultrasound is there an IUP or an intrauterine pregnancy or not? So as emergency physicians on pelvic ultrasound, we can diagnose if there's an IUP and we can say if there's free fluid or not. Now, if we happen to see some other findings, that's okay. But there's a couple things that we cannot rule out, and this is really important. We cannot definitively say that there's no pregnancy. We also can't say definitively that there's no ectopic or heterotopic. Now, what is considered an IUP? The very first stage that you'll see in a pregnancy is going to be the yolk sac, and that's this little ring here. And that's within the gestational sac, which is this really dark fluid, and that's within the uterus. The next thing that we might see in a slightly older pregnancy is going to be a fetal pull. And lastly, we might start seeing a fetal heart rate. And all of these things constitute an intrauterine pregnancy. So at this point, we have a female in first trimester with a little bit of vaginal bleeding, but a confirmed IUP. What's on our differential? So it could just be that it's a normal pregnancy and they're having some implantation bleeding and they'll go on to have a perfectly normal pregnancy. It could also be that they're having a miscarriage. Now, one other thing to think about, very, very rare, is if the patient has risk factors, it could be a heterotopic, meaning that there's another pregnancy, an ectopic, in addition to the intrauterine pregnancy. But this is so rare that it's really not something you have to think about unless the patient is on fertility treatments, such as Clomid, or you're concerned about them. They have severe pain, they're hypotensive, they have free fluid. Otherwise, if they don't have any of these risk factors, you can pretty much assume that it's a normal pregnancy or a miscarriage if they have an IUP. Okay, now let's go to the other side. Say we don't see an IUP. Well, first off, we need to look and see if there's any warning signs that something else could be going on. So if there's free fluid, if we see an adnexal mass or an actual ectopic, we need to call OB emergently because they might need to go to the OR. But say we don't see any of those warning symptoms, but we don't see an IUP. Now what do? This is where that quantitative beta-hcg level comes in. And there's a divide here, and the number is 1500, and that's called the discriminatory zone. And the whole idea is that if the beta-hcg is less than 1500, the pregnancy is probably so early that we can't actually see it yet. But if it's greater than 1500, we should be able to see something. It should be old enough that we should be able to diagnose something on our ultrasound. And just as a little reminder of what we should start seeing, if the beta-hcg is less than 1500, so this side of the line, it could be that we'll see nothing in the uterus or maybe a gestational sac. Now, if it's greater than 1500, we should be able to see something on this side of the line. Just as a quick reminder, the discriminatory zone is actually a little bit bigger in a transabdominal ultrasound. That's because the transvaginal is kind of like a magnifying glass. So you should be able to see something at a younger pregnancy. So say we do our beta and it's less than 1500. Well, now what's on our differential? So it could be that this is just a really early pregnancy. Maybe it's only 3 to 4 weeks along and we shouldn't be able to see anything yet. So that's fine. It could also be that they're having a miscarriage. It could be a really early pregnancy, 3-4 weeks along, we can't see anything yet, and now they're miscarrying. Or it could be that the pregnancy was actually a little further along than we thought. Maybe a week ago we could have seen something, but now it's kind of on the downhill. Basically, they've passed a little bit of tissue, so we can't see anything anymore, and the beta-hcg is downtrending. So both those things are not dangerous for the patient. They can be discharged home and follow up with OB. But here's the big catch. It could also be that they have a really early ectopic. And the thing here is we can actually still send this patient home because it's so small that it's not going to cause them any harm. But what are we going to do to prevent them from being in danger in the future? In these patients with no IUP and a beta-hcg less than 1500, we have to have them follow up either in the ER or in OB clinic for a 48-hour repeat beta-hcg check. If the beta-hcg is increasing, they're going to keep doing ultrasounds until they can really confirm that that's just an early pregnancy and not an ectopic. If it's downtrending, it probably means they had a miscarriage. But what if the beta-hcg is greater than 1500? We should be able to see something intrauterine, but we're not. And also remember how I said before that as emergency physicians, we can't rule out definitively that there's no ectopic. We're just not quite well trained enough. So this is the patient that we actually need to call OB for. Now this isn't the emergent consult where we're going to rush the patient to the OR. This is just to have OB come see the patient and use their expertise so that they can rule out an ectopic. If OB clears the patient and thinks that it's safe for them to go home, probably what's going to happen is they're going to end up back in this algorithm where they come back in 48 hours to the OB clinic, get a repeat beta-hcg, get serial ultrasounds. So hopefully that helps to review the algorithm of first trimester bleeding. Here's some references, and thanks for joining us on EM in 5.